Welcome to Doctors on Call. I'm Jenna Miller. One of the most common knee injuries is an anterior cruciate ligament, or ACL, sprain or tear. Athletes who participate in high-demand sports like soccer, football, and basketball are more likely to injure their ACL. If you have injured your ACL, you may require surgery to regain full function of your knee. This will depend on several factors such as the severity of your injury and your activity level. About half of all injuries to the anterior cruciate ligament occur along with damage to other structures in the knee, such as articular cartilage, meniscus, or other ligaments. Can these injuries be prevented? We'll discuss this topic and more today on Doctors on Call with our guest, Troy Moore, doctor of physical therapy.
Presentation of Doctors on Call on Smoky Hills PBS is made possible in part by an underwriting grant from
Regional Hospital, experts, neighbors, friends.
Prospectively Healthy and Wellness Clinic, where health and wellness begins. Naturopathic medicine, IV therapy, and wellness services.
Our team at Smith County Memorial Hospital is always striving to exceed expectations of our patients and guests. Your family is our family.
Troy Moore received his undergraduate bachelor's degree in kinesiology and sports medicine from Emporia State University and his master's of science in physical therapy degree from Wichita State University. He graduated with his doctorate of physical therapy from Regis University in Denver. He's a certified strength and conditioning specialist and has practiced generalized physical therapy and orthopedics and sports-related physical therapy and rehabilitation for more than 20 years in Central Kansas. Troy is the director of physical therapy at Ellinwood District Hospital, provides physical therapy for Barton Community College Sports Medicine Department, teaches Introduction to Sports Medicine at USD 355 Ellinwood High School, and serves as the Kansas Federal Affairs Liaison for the American Physical Therapy Association. Doctors on Call brings you information which may be useful to you when you see your own physician or physical therapist. Thank you so much for coming back, and we look forward to all your information you're going to give us tonight. First of all, let's talk about some of the causes of an ACL injury.
So many causes. We see them for a variety of people, a variety of ages, a variety of athletes. But typically what happens when you tear your ACL, your tibia moves too far forward. Your tibia is your shin bone. And that usually happens from either a contact or a non-contact injury. Actually, 75% of all ACL tears out there are non-contact, which means nobody touches you. It's usually when an athlete is trying to slow down or rotate or pivot too fast, and something in the knee just simply gives out. So that's the most common thing. The other 25% are contact, which usually happens in a football situation. You get hit from typically the outside of the knee, and it causes rotational thing. In our area of the state, I see a lot of farmers that get kicked by cattle, or simple people slipping off trailers, slipping on ice. There's many causes, but those are the two biggest things that I see.
Okay, well, so you've been doing this for 20 plus years,
Yep.
and it just seems that we hear a lot of ACL, MCL tears. What's going on?
Several things. In the athletic world, I believe we might be overdoing our sports or overemphasizing some things. For instance, where we're from, a lot of kids will go from one practice to the next and do not get probably adequate recovery, adequate nutrition. The game is getting faster. The game is getting more dynamic where you're cutting stronger, but yet our bodies have not changed. So we're still have the same need, the same structure that we're born with, but the demands on us are getting higher and higher. And I don't believe we are getting enough rest, or a lot of times we're seeing that kids are emphasizing maybe on one sport instead of multiple ones. It's actually safer to do multiple because your body can learn different dynamic movements. So that's what I think is going on.
Sure. Now, you mentioned adequate recovery. What, in your opinion, does an athlete need to do to get that adequate recovery?
So if we're traveling from one sport to the next and we're just driving as fast as we can and we're not putting nutrition in our bodies and we're not allowing those muscles to recover from the first practice, typically it's in that second practice that your muscles are already fatigued, and it cannot, de-accelerate as well. So you may be landing from a jump, you may be trying to stop really fast. Well, those muscles are already worn out from the previous practice, and you're going to have troubles with the second one. So typically within 24 hours, you're recovered. Most athletes will recover fairly quickly, but what we're seeing with multiple sports is it's just back to back to back, and we just don't have enough time.
Sure. Now, you mentioned doing multiple sports is a good thing. What about, a lot of times you'll hear these kids or athletes in general are doing multiple sports at the same time. How do you feel about that?
I'm a sports fanatic, so I actually love it. My own kids participate that way. It's tricky, though. So if we're going to push demands that hard, we really have to start focusing on preparing our bodies for that. So it's a good summer program. But more importantly, day-to-day, hydration is key. Are we drinking enough water? Nutrition. Are we consuming enough calories to maintain good health? So we all want good performance, but we can't have good performance if we don't have good health. So it's estimated that a female athlete in a team sport needs to consume 3,000 calories a day. That's a minimum. From the patients I have, I think we're struggling in that department. Obviously, like protein, carbohydrates, stuff like that is important, but really just consuming enough calories to maintain your body's engine is very important and a key to prevention.
Sure. Now, you hear that not all calories are created equal.
Yes.
So let's talk about that.
Okay.
How do we get those good calories?
So we kind of always base everything on protein, and we like to say 1/2 gram per pound of body weight. So you can kind of start doing your calculations. I think we all think we eat enough protein, but for these people that are running, jumping, and busy all the time, I don't think we do. And I think we really need to start doing extra to maintain that body mass, the strength, all that stuff. And I just think most kids aren't consuming enough or not enough protein, therefore we're burning out, and then here we are at practice 1 and 2 in the evenings.
Sure, absolutely. Now let's talk about the difference between an ACL and MCL injury.
Sure. So I'm going to look at the model here. If we look at ACL, the ACL is on the inside of the knee. So anterior would be front, and then cruciate in Latin would be crossed. So this ligament right here is the ACL. It's on the inside of your knee. So the MCL on this knee would be right here, and it's on the medial collateral ligament. It's on the outside of your knee. So the biggest difference would be if you tear your ACL, as of right now, that cannot heal by itself. It does not have enough blood flow in there to heal itself. The MCL, for most cases, will heal by itself because it's on the outside and it has enough blood flow. Now, unfortunately, they usually happen at the same time. But it's rare that I rehab an ACL. The MCL will heal by itself during the rehab. They don't have to surgically correct that. So, unfortunately, the medial meniscus, which is on the inside as well, attaches to the MCL. So as this tears, and that tears, and that's called the unhappy triad. And unfortunately, it's very common because of the mechanism of injuries during that.
Okay. Now, I've also heard about the LCL. Let's talk about that.
Sure. So lateral collateral ligament, it sits on the outside of your knee. Probably a less common injury because a person would have to be hit from the inside of their knee. So if you think in sport, a lot of times it's hard to get between the knee. It happens. But when I see LCL injuries, something pretty high speed had to happen. These are big, broad ligaments. They're highly protective. So when I see them tear, I know that happened at a pretty high speed event. But again, it should heal by itself without surgical correction. It just takes time. A ligament on the outside of your knee will take up to 16 weeks to fully heal.
Absolutely. And there's one more?
The PCL. So posterior cruciate ligament, it sits behind the ACL. So the ACL is always anterior and the posterior. I actually see more PCL tears in car wrecks. A person's knee might hit the dash and shoves their tibia backwards. Also, football injuries where they get hit directly in front of their shin, that will push the tibia backwards, and that will create a PCL tear. So it's uncommon. It is surgically corrected, or it can actually heal by itself as well. Our PCL is just not as an important structure in our knee, and we can survive with a loose one or without one.
Okay. Now, does genetics have anything to do with how the makeup of a knee?
Absolutely. So, first of all, some people are bow-legged, some people are knock-kneed. That usually comes from your mom or dad, grandma and grandpa. Also, I believe that osteoarthritis of the knee is genetic as well. So when I have somebody that has a total knee, I always ask, well, did your mom and dad have one? Did your grandma and grandpa have one? Typically, they're passing along that osteoarthritic gene to you, and that's very common. So yes, genetics play a role. And I have seen several times where the mom might tear her ACL in high school, and here comes the daughter too. But typically, that's because of this structure right here that's called the femoral notch. And unfortunately for women, they have a narrow one. So the ACL has less room to move, and during these rotational events, it will tear easier. That's a genetic trait as well.
Very interesting. Well, we're going to go to the phone lines. We've got Connie on the line from Dodge City waiting to ask a question. Hi, Connie. Go ahead with your question for our physical therapist tonight.
My knee is totally bone on bone, and I don't know exactly what that looks like. They can't do surgery because I'm on oxygen.
Connie, have you had an x-ray on that?
Yes.
So let's explain what bone on bone means, because I hear that several times, and that's a common thing I hear. Bone on bone means, if you look at the shiny part of this model, that is articular cartilage. Okay, and in a knee, you have a certain amount of that. And once you wear that out, you now have exposed bone. So I always use the analogy of a car tire. When you're born, you have 100,000 miles on your tire, but as we age, we wear that tire down. That's the cartilage coming down. We don't have a fix for that except for a total knee. Now, Connie, if you can't have surgery, you could try bracing, you could try injectables. Physical therapy may work, it may not, because once you're out of cartilage, you are just out of cartilage. So unfortunately, this is a tricky situation, but there are injectables that you should ask your physician about, and they're not as good as our articular cartilage, but they are, I kind of like pothole fillers. They're the asphalt that they put on the road. They fill holes, but they're just not as good as what we're born with. That would be my suggestion for Connie.
Okay, great advice. Is there a way to protect your cartilage?
Yeah, so we know now through research that actually sedentary lifestyle puts you more at risk. So I hear a lot of people say, well, I don't want to be a runner. I don't want my knees to hurt. It's actually wrong. Being active, putting some stress through your cartilage is actually healthier. So walking, jogging, whatever doesn't hurt is fine. Smoking has been proven to knock out your articular cartilage as well. Dehydration, but also just a lot of this happens from maybe you're jumping off something really high. Your job has a lot to do with this. So having a job where you don't have a ton of impact and stress on your knees does make a difference.
Absolutely. And what type of knee injury prevention plan do you utilize?
So for ACLs, we're incorporating a new plan, and it's kind of multiple layers. Nutritional is one that we have to look at. If you're not healthy, you're probably not going to prevent knee injuries. So we got to look at how much you're consuming, how often, body weight, whether that's too much, too less, those types of things. FIFA 11 is the new prevention program. FIFA is a soccer program, and this new program is teaching kids how to not only run and jump, but land properly. So when you're landing from hitting a volleyball or a rebound, is your knee in the right position? So a lot of the prevention programs are now gearing towards landing, because that's where we're seeing a lot of the non-contact ACLs. And then the final piece is weight training and having a good quadricep and hamstring. So quadriceps on the front, hamstrings on the back, and having a good ratio. One's not too much stronger than the other, because we know now that the hamstring, the muscle in your back of your leg, is your ACL preventer. So any weight training program that contains hamstring strengthening is highly recommended.
Sure. Now, how common are knee injuries to non-athletes?
Pretty common. I see a lot of meniscus tears. So January 4th was a good example. We had an ice storm down in Ellinwood, Great Bend. I'm sure everybody had ice. We saw lots of injuries just from slipping, just from twisting that knee. So we see a lot of just knee pain. Probably osteoarthritis is the most common thing we see. But a lot of it's just simple meniscus tears and what we call degenerative changes. Maybe they just twisted too wrong, or that old football injury from high school is coming back to haunt them, and things have just worn out. So those are the most common non-athletic things we see.
Sure. And how soon after a person has had their ACL, MCL repaired, whatnot, do they come see you?
Yep, good question. So 24 hours or 48 at the most. They wake up with a brace. That brace stays on until they see us, and then we start moving it immediately. Every surgeon has their own protocol. And they specifically say, hey, I want this to move this much at this time. And we follow this protocol very closely, because the last thing we want to do in rehab is injure their repair.
Sure. And who needs to consider ACL reconstructive surgery?
So right now, we're saying that anybody below 60 years of age should probably have their ACL replaced. Now, at different ages, they may repair that differently. So if you're young, under 30, they're going to take part of your own knee and fix your ACL. After about age 40, we actually recommend like a cadaver graft. It's less recovery. You're probably not involved with high impact sports anymore. You just have less demands. Things have settled down in your life. So, but if you don't fix it, then what happens is that knee is unstable. And if that knee is unstable, it will wear out faster. So we recommend, depending on your activity levels, you should consider getting it fixed. Otherwise, you're risking probably a total knee in the future.
Sure. And how much time does it take to recover?
9 months. So why 9 months? So athletes right now, when can I start playing sports again? 9 months. When can I do this? I always say 9 months. Biologically, we know that the ACL takes 9 months to fully grow in, okay? So when the surgeons put this graft, they have to screw it into the bones. Well, that graft has to heal down. So research shows that 9 months we're safe and we will not rip that thing out or re-tear. So that's actually extended. When I first started 20 years ago, 4 to 6 months. And then we probably started doing some research. Hey, these are re-tearing. And so now we're at 9. And we know biologically that's a good place to be, that thing's fully healed.
Sure. And how long are they doing physical therapy, although it's 9 months?
A version of it. So the first 3 months are pretty heavy in PT, coming to the clinic, coming to the hospital. After 3 months, it's more supervised weightlifting, strength training. After about 6 months, I really throw them back into like some coaches, doing some practice things, letting them kind of, with guidance, do their own thing. They're still checking in with me, but at 9 months they have to do a very strong, like intense functional exam. I make them run, I make them jump, I make them do all kinds of things, and we're calculating the difference between the good knee and the bad knee. And they have to be 95% of their non-surgical leg to be released. So I'm always kind of in charge of them for 9 months, but a lot of times they're on their own I won't see them as often.
Sure. Let's rewind a little bit. Once they come see you first, what can a patient expect?
The biggest thing is I have to gear them up for, be patient. We're in a society where things just have to go so fast. And remember, this thing is growing. This thing is like a tree that has to grow tall or strong. So we cannot rush certain things. But what can you expect? Lots of movement, using some electricity to get your quadricep going, balance training, but range of motion, home exercises, discomfort, unfortunately, for the first 2 weeks. So getting good on crutches, getting good on your assistive devices. In my world, it goes pretty fast, but I'm sure in their world it's slow as can be. But for the first month after ACL or pretty much any knee surgery, it's just a rough time. Lots of swelling, discomfort, you limp a little bit, and you just got to be patient with the process.
So let's talk about the difference between tearing fully and just a partial tear, and the difference between that.
That's a good question. So There's 3 grades of a tear, 1, 2, and 3. It's hard to identify on MRI. It really is. You really have to have that scope, put a camera in there to really see what you got. There are some new technologies that they're trying to inject into a partial tear and see if it can grow back. There's also some other surgery where they're attempting to maybe tie that back together. So that would be a partial tear. You still rehab it the same. You still got to build everything back up. Depending on your activity levels, you can be successful. But a full tear means it is gone and it is not going to grow. And it's the full 9 months and it's surgery and all that stuff. But you can survive without an ACL. It's a risk. If you remember John Elway for the Broncos, he did not have an ACL the last 3 years he played. And he did pretty good. Now, has he had total knees since then? Probably. But so you can rehab to the best of your ability. You may have to reduce your activity level or wear a brace if you don't have it corrected.
Sure. Now, you've mentioned total knee a couple of times. Let's talk about when you know you got to have it done.
I always say when you can't sleep at night, when you are losing range of motion, so you can't bend that leg to get in your car, or you're having trouble getting on and off the toilet or stool, or your pain levels are just kind of excruciating. It's past due at that point, but really sleeping at night or instability where the knee's just giving out on you because you just don't have, it's painful, that's when I'd have it done. And that technology has even gotten even better. And what used to take us 6 to 8 weeks for rehab, it's really 4 now. The robotic knee and even the non-robotic, we're just getting so good at these because they're so common. So very similar rehab processes, except for, you know, those total knees they're cemented down. They're really hard to mess up. Whereas that ACL, you got to be more careful.
Sure. And at what point, or how do you know when you go to the doctor if a person has knee pain of any kind? When is it time to go to the doctor?
I always say when you've given it 2 weeks and you've tried the standard anti-inflammatory, so Advil, ibuprofen, you've kind of babied it for 2 weeks. If it is noticeably larger, so if you look down at your knee and it just looks like a big water balloon or a big, you know something's wrong on the inside. So obviously sleeping at night is difficulty, and if you cannot bear weight, that is the time to go. You've got to rule out a bony issue at that point. So basically, when it's really big, when you can't bear weight, and you're just struggling with normal activities of daily living.
Sure, absolutely. We had a caller that just gave us a message, I guess, wanting to know what the typical surgery is for an ACL injury.
So there's a couple ways to fix it now. The most common way is called a patella tendon bone graft. So this thing is our patella tendon right here. The surgeon would typically remove about the size of a pencil or about the size of your pinky finger. And he removes that from there, uses some screws, and he reattaches it into the femur and the tibia. So that thing will run this way. It works really well. It's a standard right now. We're also using this part called the quad tendon. But either way, it's going to be at least a little bit of a surgery, a scar, and a couple scope holes. So they're in there. They have to have a camera in there. They have to be flushing your knee out. So a lot of it's just a small incision, maybe 2 to 3 inches long, and then some little incisions to look in the knee, and they can fix almost anything else with just the scope now. So depending on the size of the meniscus tear, depending on the damage, surgery could be 1 to 3 hours. 3 is pretty long these days. So you're under anesthesia a couple hours, you wake up, and most of the time you go home within an hour, and you start PT within a day or 2. So that's kind of the typical what we see.
Okay, great. Now, how often do you see a patient that comes into physical therapy and is able to avoid surgery?
For the knee, for my older adults, physical therapy has been really effective. We can do different things, ultrasound, dry needling, electrical stimulation, but just a lot of it's just getting the cartilage rebuilt up, giving it the correct nutrition that it needs. Movement is really probably our best medicine right now. Finding movement that doesn't hurt is key. There's even some good bracing or taping methods. So I'd say about half of our knee patients, we avoid it unless there's just a structural damage. So the bone-on-bone patient probably needs to progress to a total knee. I can't replace cartilage. love what I do, but we just can't replace that yet. I think in the future we'll be able to with stem cells or some other type of injectables. We're just not there yet on a consistent basis. But I'd say about half we usually help pretty good. The other half have some type of structural damage that needs fixed.
Absolutely. Okay, great. Vance, we're out of time, and we filled it with some great advice, great information. So thanks so much goes out to Troy Moore for being our guest tonight on Doctors on Call. On our next Doctors on Call, we'll be discussing wound care. You can email questions. That email address is doctors@shptv.org. Thank you for joining us for Doctors on Call. I'm Jenna Miller.
Presentation of Doctors on Call on Smoky Hills PBS is made possible in part by an underwriting grant from
Russell Regional Hospital. Experts, neighbors, friends.
Prospectively Healthy and Wellness Clinic, where health and wellness begins. Naturopathic medicine, IV therapy, and wellness services.
Our team at Smith County Memorial Hospital is always striving to exceed expectations of our patients and guests. Your family is our family.